topic is the site-specific physics plan review focusing on palliative, 3D palliative, and SBRT spine, and sarcomas of the extremities. It is my great pleasure to introduce Dr. Dustin Jacqmin as an educator for this session. Dr. Jacqmin is an associate professor at the University of Wisconsin-Madison in the US. He also serves as the Director of Quality and Safety in the Department of Human Oncology, as well as the Director of Quality Assurance and Patient Safety in Physics Division. This session is meant to be interactive, so please feel free to write any questions you may have in the chat. We will do our best to address your questions during the session or in the chat as appropriate. With this, I'll hand it over to Dr. Jacqmin.
Thank you, Minsun. I appreciate that lovely introduction. Good morning, everyone. It's good to see you all again. I had the opportunity to moderate last week and spend some time with you, and today I get to present again. First time I presented was the long lecture, and I was very sick, and I am happy to say that I feel a lot better today. So hopefully I won't lose my voice, and we'll have a nice presentation here. All right. So this presentation is kind of a collection of a few different topics that we chose to put together into a single session. You know, you've been going through this physics plan review process, this checklist, you know, many weeks in a row. And I think by now you've all seen it so many times that you could probably do it in your head. And so this is an opportunity to kind of focus in on a few topics and pick some, you know, major themes within those topics. And rather than going through the entire checklist for each of these topics, we'll highlight some of the most unique and distinctive issues related to reviewing plans within these categories. So the three topics are palliative radiotherapy, spine SBRT, and sarcomas of the extremities. The last one being an opportunity to talk about treating arms and legs, which we haven't had a chance to do yet, and there's some unique challenges there. So this is kind of the outline. You've seen this slide many times. Really, for each topic, we'll be jumping kind of through relatively quickly and then circling back to the beginning again for the new topic. But just a reminder of kind of the overall structure of these presentations. So let's start with palliative radiotherapy. For each of the three topics, I'm going to start with patient assessment. You know, in each case, we've talked about this week after week, but patient assessment is always the first step of physics plan review, and it's one of the most important. It's where you have an opportunity to, you know, kind of orient yourself and ground yourself in the patient's history and situation, learn a little bit about what happened to them that brought them to you, so that you can approach the physics plan review process with the right mentality and the right information. So what's special about, you know, palliative radiotherapy? You'll get a physician's written order for treatment planning. One of the things you might see is that there's often a lot of treatment sites. You know, in my clinic, it's not uncommon to see between 3 and 5 different sites being treated for a palliative care case. You know, sometimes it's just one, but there's a couple of cases I'll be showing today where a patient had, you know, 5 to 7 different sites that we were treating over the course of a few months. And so, you know, oftentimes we're just reviewing one plan, one prostate primary, one prostate boost, or one rectal cancer case or something like that. But in the case of physics plan review for palliative radiotherapy, you might have multiple sites at the same time, which means it's good to get a sense of, you know, what sites are we treating? What is the laterality of those sites? What are the prescription doses for those sites? Because those may differ as well. In addition, you know, sort of by definition, patients who are receiving palliative care are sicker than average than, you know, the radiotherapy patients we're treating more often. They're going to be in pain. Often they're close to end of life. They may have other comorbidities that make treatment difficult. You know, pain makes it difficult to lay down sometimes. It makes it difficult to achieve certain positions or stay in the same position for a long time. So it's really important to understand at the time of patient assessment, you know, what is the condition of this patient, and, you know, how is that going to affect our ability to treat them? Let's talk about simulation. You know, with palliative care, often simulation ends up being, you know, fairly simple. You know, we want the patient to be comfortable, but we also want to be able to set them up and position them as, you know, as quickly and safely as possible. And generally, we try to use fewer resources for these cases as well. to keep the cost of care down as well. There are some specific things related to palliative care where, there's certain patient setup challenges that are important to consider. So one thing we've been talking about over the course of several weeks is identifying internal and external anatomy that can be difficult to position and affect the treatment volume. If we're treating the C-spine or the upper T-spine, kind of where the shoulders are, that can mean that the shoulders are in play in terms of being able to move up and down and potentially block the treatment fields. And so anytime you're treating C and T spine, where you're crossing the shoulders, there's opportunities for difficult patient setups that need to be thought about. In addition, hands and elbows need to be positioned carefully to keep them out of the treatment field. It's often the case that a palliative care patient might not be able to put their arms up. And so they'll have to have them down or on their chest. And you can do a number of things to position them out of the radiation field. First you have to know generally where you're treating, and then, of course, position the arms accordingly. Alternatively, you can just choose beams that avoid the arms, but that is something that comes up more often in palliative care radiotherapy. Lastly, and this is something that happened in my clinic just a couple of weeks ago. We had a patient who was getting palliative care to multiple sites and was scanned in different positions for each treatment site, and the scans overlapped a little bit, such that you could pick 1 or 2 scans for each treatment site. And the dosimetrist accidentally picked the wrong scan for the C-spine. So there was like a lower C-spine. They picked like this upper thorax scan instead of the kind of the head and neck scan. And we had to adjust and make things work. But when you have multiple sites and multiple scans, things can get really complicated. So it's good to look at, when the CT simulation therapists or whoever's setting up patients in your clinic, when they took this scan, what were they intending to use it for? Did the dosimetrist match this scan to the right intent? And do we have a plan on the right kind of scan? That is something that can come up when you have lots of treatment sites at the same time. Here's an example of shoulders being in play. So we have, 2 relatively closely spaced spine targets in this patient. One is above the shoulders, as you can see, and then one is below the shoulders. The one that's above the shoulders is also pretty close to the same height as the chin. And so we have like this, the chin, which is this mobile structure, the shoulders, which is a mobile structure. And so this setup is going to be challenging. And there's this other aspect, which is that this upper target is at like a depth of 6 to 10 centimeters depth. The bottom target is much deeper. You got to go through the shoulders potentially, or even if you don't, the chest is deeper than the head. So, if you tried to treat this with a single plan, you'd probably have a really non-uniform dose distribution. So pretty tricky setup, a pretty tricky planning scenario. We'll circle back to this one a little bit later to discuss how the dosimetrist solved it, but here's a great example of 2 closely spaced sites near the shoulders and the chin. Here's a clinical example of an issue that happened in my clinic. So we had a patient simulated arms up on an upper treatment of the upper chest for L-spine. So you can see that we have an L-spine target here, and the patient's arms are on their upper chest, positioned pretty high on the upper chest with the elbows almost straight out at the side. And then when we scan the patient for treatment, the patient's elbows had dropped down to the level of the treatment field. And in this particular case, they had used some pretty wide oblique angles coming from behind, such that they were getting pretty close to the elbows here. And so we had to actually, adjust the patient's position and get the elbows up and out of the way. And of course, we learned from this, and we had some notes in the patient's chart to prevent this going forward. But this is kind of an example of how the patient's arms aren't up and over their head. They can kind of drop into the treatment field if you're not careful. A quick note on non-biologic materials. It's fairly common for patients to have prostheses and metal in their arm, or screws in their spine. Just generally orthopedics of some kind to help support the patient when they've had problems with their bones. In palliative radiotherapy, we see these prostheses and they have unknown materials, and it may be hard for us to get information about the prosthesis in a timely manner due to the short turnaround time needed for planning. With a conventional radiotherapy case, we often have 5, 10, 12 days to plan. That's plenty of time to do a little bit of hunting to figure out what the material composition of an implant is. But for palliative care, often we have, hours or maybe just a couple of days to plan. And, it can be difficult to figure out the material composition of that prosthesis. So, given these circumstances, and given that the goals of palliative radiotherapy are urgent pain relief and not cure, it is often reasonable to assume that an unknown material is titanium, plan accordingly, accept the additional uncertainty associated with the, maybe the wrong material composition, knowing that you're going to be pretty close, and that if the overall goal is pain relief, it probably doesn't matter for that kind of case. All right, let's discuss some elements of treatment planning specific to palliative radiotherapy. In general, the best plan is the simplest plan that meets the goals of treatment. There's a few different techniques you can use in palliative. So, static fields, dynamic conformal arcs. Sometimes you can use field and field, like for breast, just to even out the dose distribution a little bit, but generally you want to keep things simple. So, simple beam arrangements that are efficient to deliver are generally preferred. This minimizes patient's time on the table, maximizes comfort for the patient. You also want to, be mindful of deliverability and avoid collisions or angles that may be affected by poor patient setup. So we talked already about upper T and lower C spine, where the shoulders, the chin, the arms may impact deliverability. And again, positioning of the arms just generally in the thorax, abdomen, and pelvis is just something you have to keep a close eye on to make sure you don't inadvertently treat through those body parts and attenuate the beam in an unintentional manner. From here, I'm just going to show a bunch of examples of treatment field setups and their clinical rationale from my clinic. So this is a treatment of the C2 vertebral body, pretty small target, kind of mid to upper head and neck. You can see here that we chose to do a pair of laterals. The reason was that the physician's main organ at risk was this pink, oral cavity mucosa region. The physician really wanted to protect that more than anything else. And so this pair of laterals arrangement was the plan design that optimized dose to the mucosa and minimized it as much as possible. Here we have a simple treatment of the left shoulder with APPA fields. It's pretty obvious just by looking at the picture that the shortest distance through the patient into this target is APPA. And so this is just it's not only simple, but it's also very efficient. It's going to give you the lowest hot spots. And you can see this plan looks, very nice. This is a very common arrangement in my clinic. We call it an inverted Y arrangement because if you look at it in an AP, I guess if you look at it in a normal treatment planning view, this axial view, it looks like a Y, but it's upside down. This is a nice field arrangement if you want like a relatively conformal shape. This kind of makes a six-sided kind of hexagon shape in a small number of fields. This is especially nice in the abdomen if you want to kind of skirt past the spine or something like that. But in this case, you can see it's being used for the upper T spine. So we have two posterior fields, one anterior field, and the posterior fields have these wedges to even out the dose distribution. But again, a relatively simple field arrangement for treatment of a T spine lesion. The nice thing about this is this avoids the shoulders, so we don't have to worry about the setup uncertainty associated with arm positioning here. Another example, this is not quite APPA, it's opposed obliques, so a little bit off APPA. But again, we're treating the elbow joint here and avoiding the body, so we're kind of running tangent to the body. But another simple field arrangement using two fields that produces a nice, relatively uniform dose distribution to the target volume. Increasingly in my clinic, we're using 3D conformal arcs for palliative cases. These are nice. You end up making a single field, just like auto fitting it to the target volume. And then in RayStation, you can place a little bit of optimization. Say you can put a uniform dose optimization goal, and it'll just modulate the dose rate. So if you see this little wheel down here, where the orange goes all the way kind of to the center, that means the full dose rate is on. And then where the orange is kind of tapered back toward the edge of the circle, that tells you the dose rate is going down. So this shape kind of tells you that the dose rate is uniform, except kind of at the back and a little bit from the side. And so, this treatment planning system lets you optimize a little bit on dose rate. The MLC's positions are fixed. It's still a conformal arc, but the dose rate is modulated to help make the dose more uniform. And these are relatively quick to deliver. Once they're set up, you just do a single arc and it's done. Very conformal. You can see the downside is that you have this low dose wash going into the lungs. In this case, the physician was not concerned about that and preferred to have this, conformal dose distribution. But sometimes this extra dose spill is a factor, and the physicians will prefer more of an APPA arrangement. So it really depends on the goals of treatment. We'll see another example of that in a little bit. Here's another inverted Y, not a symmetric one. One field is a little bit more lateral than the other, but same basic idea. We get this hexagon shape stretched in the APPA direction. It does a really good job of minimizing dose to healthy lung. So a nice palliative plan for this large lung target here. And I think this is the last example. This is again, treating the hip joint. APPA is, again, the shortest path through the patient here. And so this sort of will give you the lowest hot spots for any kind of, two beams. Occasionally, I'll see a third beam added from the side to make the dose distribution more conformal. If there's really big hot spots, we might do this in larger patients, but for the most part, most hips we're going to treat with a APPA beam arrangement. This does a nice job of sparing the rectum and the bladder pretty much entirely. They're totally out of field. So I apologize, the Zoom questions aren't set up today. So we're just going to have to, take a moment. You can put your answer in the chat if you want to, or you could just keep the answer to yourself, but we'll just read the question. We won't have the polls, and we'll just take a minute to think about the answer, and then we'll answer the question. I'll even set up a little timer here. So which of the following is not a typical beam arrangement for palliative radiotherapy? And I'll set a 1-minute timer starting now. I see lots of people dropping answers in the chat. That's great.
Everyone is choosing 3. I have a quick question, Dustin. So,
Yeah.
How's the treatment time for the conformal arcs? Is it just like as quick as the APPA? And also, what kind of a QA do you do for that case?
So treatment time, I guess like both APPA and the conformal arc are I think that the treatment time is really bound by how long it takes the gantry to rotate, because the actual delivery, a conformal arc is generally delivering more or less at maximum gantry speed. And so it takes about a minute to deliver the arc. The APPA, you'll deliver one field, you'll rotate down, that takes 30 seconds, you'll deliver the other field. So, maybe the APPA is a little bit faster, maybe 10 or 20 seconds faster, but they're pretty competitive with one another. Yeah. And then
QA?
For 3D conformal arcs, no, we don't do any QA above and beyond like a normal physics plan review. We commission 3D conformal arcs as part of our standard treatment planning system commissioning process. So in the same way you would, deliver treatment field and then check them at the time of commissioning, we deliver some 3D conformal arcs and verify that the dose calculations are accurate. We don't treat it like IMRT in that sense. We did, I'll say we did commission this technique like specifically. So we created a bunch of plans with this dose rate modulation, and we measured them and just more or less determined that our treatment planning system was able to create these plans safely. And that was sort of where we landed on that. All right, so the correct answer is option 3, which I think most of you got. So 7 fields is, quite a large number for a palliative case. Maybe in the pre-IMRT era, you'd have a 7-field conformal plan for curative intent, but these other examples here are good examples of plans for palliative care. So here's a clinical example, kind of a compare and contrast. These are 2 plans generated for the same patient. These are both plans generated by a dosimetrist for a physician to review. We have a 3D conformal plan down on the bottom, showing that classic inverted Y. In this case, it looks like a 5-sided shape, but you can see that it does a good job, sparing the kidneys, which I guess I should have picked a different slice because you can't really see the kidneys here, but the kidneys are kind of at the top of the target volume, lateral to the target. This arrangement does a really good job protecting the kidneys. On top, we have the conformal arc. It keeps dose out of the bowel really well, as you can see, but it does give a little bit more dose laterally to the kidneys. And you can see that here in the DVH, the solid is the conformal arc, lower dose to bowel, this pink structure here. The solid green is the kidneys, higher dose to the kidneys and conformal arcs. In this case, the physician wanted lower dose to the kidneys, so the physician chose this 3D plan. But another physician for a different patient may choose the other plan. So these are kind of competitive with one another. And it kind of illustrates, depending on what your organ at risk goals are, it may determine which technique you end up using.
Dustin, I think there is a question from the chat. So what's
Oh,
the
sure.
max dose for kidneys for 3D RT?
Oh, could you repeat that? I missed the question. Could you repeat the question?
Oh, I'm sorry. So what's the max dose for kidneys in 3D RT?
The max dose for what?
Kidneys.
Kidneys. Oh, good question. So often you're looking at the V18 gray. It's very rare that you'll actually exceed sort of the traditional tolerance dose in palliative radiotherapy. So very often the physicians in my clinic just want the kidney dose to be as low as possible. The kidney is this parallel organ, so any radiation exposure to it causes some loss of function. And so, when a patient is in a palliative care situation and their kidney function is already compromised, very often the physician just wants it to be as low as possible. So I don't know that there was a goal in this particular case for kidney dose. I think the physician just said, like, show me some plans. I'm going to pick the one with the lowest kidney dose. And that's ultimately what they did. You can see this is a single fraction treatment too. So the kidney dose probably was 2 gray average versus maybe 3 gray average. So low across the board. And the physician just wanted it to be as low as possible. All right, let's talk about half beam blocking. Half beam blocking is this technique where you move one of the jaws to the 0 position such that you have this perfectly straight divergent line passing through the patient. And it's a very useful technique to avoid variable anatomy, protect organs at risk, and match treatment fields to previous radiotherapy. So I'm going to show you a couple examples where this can be useful, but examples include things like treatment of the C-spine to avoid the shoulders. In the L-spine, if you're treating the L-spine, the S-spine, and the hip, you can kind of use half beam blocking to optimize dose to the bowel. And of course, previous radiotherapy, if you're trying to match previous treatments, using half beam blocking is a really straightforward way to do that. So here's a half beam blocking scenario for L-spine, sacrum, and femur. You can see that we have a 3-field arrangement here, 2 laterals and a posterior. This helps reduce dose to bowel by not having an anterior field. We're also treating, it's I guess a little difficult to see, we're treating the right hip as well. You can see it here, you can see it up here. And so what the dosimetrist did is they created this kind of typical 3-field pelvis plan, and then added a APPA plan at the bottom, and there's a half beam block in the middle. So like the bottom half is treated by fields below the 0 position on the y-axis, and the upper fields are treated above. This allows you to do everything in a single isocenter and not have any divergence from one treatment field into the other. So this is a nice way to make sure that you're not accidentally diverging from the hip field into the L-spine field or vice versa. It's also very efficient because you're doing everything in a single isocenter, which is very elegant. And then here's that case I showed near the beginning of this presentation. The dosimetrist actually used a single isocenter and half beam blocking here to treat both of these targets at the same time. So there's no divergence from one target into the other target, which is nice. So you don't have any overlapping dose. And then by splitting the field into like an upper and lower component, they're able to use different monitor units and different jaws to like make sure the dose distribution is as even and uniform as possible. You can imagine that below the shoulders, the number of monitor units needed to give a uniform dose to these targets is higher, and above it's lower because it's a shallower depth. And of course, the wedging is going to differ above and below because the surface contour is a little bit different above the shoulders versus below the shoulders. So this is a way to have a single isocenter treat 2 targets at very different depths in different parts of the patient at the same time. So just 2 interesting examples of half beam blocking used for palliative radiotherapy. We haven't talked a lot about wedges and collimators because we don't use them very often in other parts of curative intent radiotherapy, but wedges in particular are very common in palliative radiotherapy. And wedge orientation and collimators should be used to select, or I should say, should be selected to improve dose uniformity and conformality of the dose distribution. So for wedges, it's all about making the dose distribution more uniform. Collimator angles, you can use that to, find the best shape to make the dose distribution as conformal as possible. You can also use it to block organs at risk if needed. One tricky thing is that if you're using a linear accelerator that has the wedge either built in or creates virtual wedges, like the variant EDW. The wedge orientation is fixed relative to the collimator. And so, and of course, the MLCs are fixed relative to the collimator too. And so the relationship between collimator angle and wedge angle are kind of like mixed together a little bit. If you want a lateral wedge, you have to turn the collimator 90 degrees. That means your MLCs are coming from the top and the bottom now. And this can create some difficult situations where you want to get wedging kind of left to right, but you want your MLCs to come left to right as well, because that's the optimal position for them. And sometimes you have to make compromises to get the kind of plan that you want. And you'll often bump up against these things when you're using, an enhanced dynamic wedge or any sort of wedge that's being driven by the jaws. Here's a few examples of wedging. Broadly, there's three uses of wedging. You can compensate for the patient's external not being uniform. You can compensate for asymmetric field arrangements. You can compensate for internal heterogeneities. So I have two examples here of, one on the left here of, this is a lightly sloped surface along the patient's back. The dosimetrist added a wedge to even that out, and now we have a nice uniform dose distribution. These examples here show, using wedging to compensate for asymmetric beam arrangements. So here we don't have an anterior field, and so we have wedges on the lateral fields pointed posteriorly to help make the dose distribution more uniform. In this case, the dosimetrist actually chose to make it a little less uniform to reduce dose to bowel. So you can see it's hotter at the back, cooler at the front. They could have used a higher wedge angle to make it more uniform, but they actually decided not to try to spare a little bit more bowel. So that was done intentionally. And then again, this inverted Y field, you have to have some posterior wedges to make the dose distribution uniform. Otherwise, you'll end up with a hot spot here at the back. We've talked about modulation factors that are typical for radiotherapy for all the IMRT and VMAT techniques. For 3D conformal plans, the modulation factors, that is the ratio of monitor units to prescribed dose per fraction in centigrade, is going to be lower because we don't have that modulation. Typically between 1 to 1.5 for plants without wedges. It'll be higher for targets that are deeper because there's, you need more monitor units to get to deeper depths. Shallower targets will have a, lower number. And then when you add wedges, the MU factor will go up. And here's just a couple examples. You go from 10 degrees to 30 to 45 to, you'll see here it goes from 1.25 to 1.85 as the wedge angle increases. That L-spine 3D conformal plan had a MU factor of 1.8. I think reflecting the fact that, when you're delivering from the front, it's very, very deep. And so the depth is kind of pushing this MU factor a little bit higher. You can see that none of them are higher than 2. So you're typically seeing between 1 and 2 for these 3D plans. All right, let's talk about dose distributions. It's fairly common in palliative radiotherapy to see a variety of different prescription normalization techniques. Normally for curative intent, we're always prescribing to V100. That is the volume getting the prescription dose is 95% or larger. Sometimes for SBRT, you'll shoot for 98%. In palliative care, you'll often see this prescription, which is the dose to 95% of the prescription should be covering 95% of the target volume. You may even see lower things like 90-90 to minimize hot spots and improve the safety of the plan. But it's more common in palliative radiotherapy to accept lower levels of coverage as part of the prescription. And so that's just something to keep in mind when you're looking at the way the plan is prescribed. If you see something really unusual, you should always ask the physician if that seems right to them. But this is just a typical pattern in palliative radiotherapy that's worth pointing out. Last thing on palliative radiotherapy, hotspots might be higher in palliative radiotherapy due to the use of a smaller number of treatment fields. It's also the case that hotspots might not be in the target volume, which we're used to seeing for, curative intent radiotherapy. So you can see in this particular plan, the hotspot is near the surface. Typically for APPA fields, the hotspot is near the surface because that's where the Dmax of each beam is. And so you can see in this case, we have about a 10% hotspot near the surface for this APPA field arrangement. Hotspots in the range of 10 to 15% aren't uncommon in palliative radiotherapy. Some of the plans I'm showing you here, 108%, but normalized at that 95% coverage level. So if we were going to V100, this would be more like 114% hotspot, and 110, 106. So, this 3D arc tends to give you a little bit lower hotspot because it's more conformal and more uniform. But any sort of 2 or 3 field arrangement is probably going to have some bigger hotspots. And that's okay. That's sort of typical of these plans. Lastly, accounting for prior radiotherapy is important in the palliative setting. This can be more difficult because the planning timeline for palliative radiotherapy is shorter, and so you have less time to discover and incorporate this information into planning. But of course, very often we're treating the spine in palliative radiotherapy, and the spine is this organ with a really bad toxicity. You can cause paralysis if you give too much dose to the spine. So it's really important to understand the impact that your treatment is going to have on the patient by taking into consideration all previous radiotherapy. It's also worth remembering that, palliative radiotherapy often uses higher dose per fraction, so like 400 centigrade or 800 centigrade per fraction. And so when adding doses together, it's important to use EQD2 or some other radiobiological correction to make sure that you're adding dose in a way that reflects the biological effect of the patient. And one quick example here. This is a patient being treated for renal cancer, metastatic to the lung. And the MD was aware of previous radiotherapy to the T and L spine, but didn't think it was overlapping, didn't think it would be significant, and didn't ask for a composite. But here you can see the previous treatment in the T spine, and there is some overlap with the current treatment field. In a composite, you can see here that it overlapped in such a way that there's about 60 gray going to the esophagus in composite when converted to EQD2. And the physician found this concerning. He didn't want 60 gray going to the esophagus in composite. So we replanned the case. We pulled that 60 gray out of the esophagus. But this is a good example of why it's really important to screen for previous radiation and palliative radiotherapy. The last thing you want to do is create more pain and more side effects for the patient, right? Palliative radiotherapy is all about helping the patient feel better and feel less pain. And so very important to make sure that what you're doing is safe and not going to cause more harm. Last note on palliative radiotherapy, it's important to communicate any relative information to the radiation therapists. We've talked about a few of these things. The patient condition is really important to know, as well as if the patient's arms and elbows are in a special position that keep them out of the treatment field. And so it's good to make sure that this essential information has been communicated. Which brings us to our second poll question. Which of the following is not a typical use of half beam blocking?
Please enter your answer in the chat. So Dustin, so there is a question from the audience.
Yeah.
Can changing the collimator angle modify dose modulation?
Certainly changing a collimator angle in palliative radiotherapy can do a few things. When we're doing palliative radiotherapy, we don't talk a lot about modulation. That's typically a concept associated with IMRT and inverse planning. That being said, turning the collimator can change your field design quite a bit. If you have a really long field, for example, having the collimator angle oriented, such that the MLCs are coming in perpendicular to the long target can help make the plan more conformal. And that can, change the quality of the plan quite a bit. All right, it's been 1 minute. Let's see what we have for an answer here. The correct answer is 2. You certainly could use a half beam block to block an implanted device, but most often you would just simply place that out of the field off axis. And these other examples here are uses of half beam blocking for palliative radiotherapy. All right, let's transition to spine SBRT. I have a number of references here that I use to generate the content. I just wanted to share these with you. The first is an astroclinical guideline on bone metastases. This covers both palliative radiotherapy and spine SBRT. It's a really nice resource. They actually just republished it. They just updated it for the first time in 5 years, so it's really a nice resource. NRG has a protocol for spine SBRT that they publish on their website, which is nice. And then, of course, these are 2 clinical trials that are really influential in spine SBRT planning. So let's talk a little bit about patient assessment. As always, we'll review the physician's intent and the prescription, understand the clinical background. There's a number of different doses and fractionations for spine SBRT. In addition, many patients who are getting spine SBRT have a history of prior RT to the spine, which also can influence the prescription dose. So it's good to pay attention to that. A physician might opt for a more aggressive prescription under different circumstances, better prognosis, if they have a radio-resistant tumor type that is being treated, limited metastatic disease, they might want to improve the chance of durable cure. History of prior RT, if you've treated a location and the disease has come back, then usually you want to be more aggressive the second time in order to improve the odds of having cure. And finally, generally being more aggressive, higher prescription dose, fewer fractions, maybe requires more advanced planning. And so if the patient can tolerate an extra day or two of planning time, that's something that the physician may consider as well. With respect to certain special considerations, because the spine runs the entire length of the body, there's all kinds of things that can be in or near the treatment field that we see in other treatment sites. So pacemakers are certainly in play for T-spine targets. Patients also often have implanted hardware in their spine that might be in or near the treatment field. So it's really important to pay attention to those kinds of things. And again, the patient has prior RT to the spine. We should be paying attention to the previous dose to organs at risk, like the spinal cord, the cauda, any nerve roots, things like that are near the target volume. Let's talk about simulation. Spine SBRT uses a very small PTV margin. Some places use 0, some places use 1, some places use 2 millimeters. It really depends on what your clinic is comfortable with and what it can consistently hold the patient to. In any event, all of those are really small margins, so the patient should be immobilized as much as possible to maintain those small margins. Again, spinal hardware is often near the treatment field, so you should screen for that when you're reviewing your CT simulation images. And in the event that it is in the field, it's good to identify what kind of materials are there and override the density of those materials if appropriate. Here's an example of 3 patient setups for spine. For the L spine, we have the patient in a mold and then immobilized with compression. Often we think of compression as being for respiratory gating and reducing respiratory motion. In our clinic, we also use it just to immobilize the patient. So this wrap on top of the patient will make it difficult for the patient to move, and this is a nice, safe way to immobilize the patient for SBRT. This T-spine example here is a little bit exceptional. This patient had surgery on their arm, and because of that, putting immobilization pressure on the arm was actually quite painful for this patient. And so we did use a mold underneath to have a comfortable, reproducible position, but we had to forego the compression due to patient pain. We created a comfortable place for the patient to rest their arm, and we ended up using surface imaging just to make sure the patient wasn't moving, which was the best we could do for this particular patient in their circumstances. Lastly, for C-spine treatment, we use a typical head and shoulder mask and kind of our conventional head and neck setup for those patients. Here's an example of spinal hardware in the treatment field. So, oops, sorry about that. My mouse is kind of driving itself today. So this patient had a pair of rods in their spine adjacent to the treated region, and then 2 pairs of pins holding these rods in place. Looking at the patient's medical record, we were able to determine that the rods were cobalt chromoly, the pins were titanium, and the dosimetrist was able to block the cobalt chromoly rods with a 2 millimeter margin, which we didn't apply it to this one on the left here that was in the target, but we did apply it to the one on the right, which was outside of the target. That helps reduce a little bit of the dosimetric uncertainty associated with treating through metal. But this is something you might see in spine SBRT. All right, let's talk about contouring. So one of the most critical parts of spine SBRT planning is the image registration process used to determine the location of the spinal cord. Spatial accuracy is extremely important in spine SBRT, so registrations need to be really, really accurate for whatever their intended purpose is. So accuracy of 1 to 2 millimeters is generally required. The most common registrations include fusing MRI to CT to contour the true spinal cord, fusing an MRI to the CT to contour the GTV, or fusing CTs together to assess the effect of previous radiotherapy. In the case of the first case is actually the most common use of fusion in spine SBRT. And when you're reviewing this fusion, it's really important to review the accuracy of the spinal cord, the spinal nerve roots. These are the things that have the biggest impact on the plan. They tend to be undercovered on purpose with very small margins. And so the accuracy of these contours is really essential. And the accuracy of these contours is driven by the registration accuracy, since they're generally registered using a fusion with an MRI. I'm going to show you an example here. This is a high-resolution MRI of the spine fused to a treatment planning CT. I'm just going to click here so you can see this. Hopefully you can see this back and forth of the fusion. The MRI protocol, ideally you want an MRI that's less than 2 weeks old in the simulation position if possible. That's going to reduce the amount of differences in spinal flexion. And you want the slice thickness to be pretty small. Typically for a diagnostic scan of the spine, the slice thickness is pretty big, several millimeters. And you have really bad resolution in the superior inferior direction. If you ask your radiologist to make you an image with 1 to 2 millimeter slices, it'll look a little bit sharper. It'll make the fusion a little bit easier. When you're doing the image registration or when you're reviewing it, you'll notice that differences in spine curvature might require compromises in registration accuracy. So if that is the case, you want to focus on the target vertebral body most of all, and any vertebral bodies that are immediately next to it, acknowledging that the fusion away from the target might not be as accurate. Here I have the grayscale inverted, and that makes the MRI look a little bit like normal bone. This lower right here is what the MRI would actually look like to a radiologist. So I usually do this fusion with the MRI inverted, and then I flip it back to the normal color scheme for the physician to contour, since they're usually used to looking at the MRIs in the same color scheme as the radiologist. But this is kind of just a nice little trick for helping you do the fusion. Let's talk about target and organ at risk accuracy. The general principles of making sure that the targets and organs at risk apply in general. The most important thing is that spine SBRT spans the entire length of the patient. You could be as low as the sacrum and as high as the upper C-spine. And so the types of organs at risk in play will vary a lot depending on the location that you're treating in. And so in general, the rule we follow in my clinic is you should contour all organs at risk with mean and DVH goals that are in the plane of treatment. So any like planes that the beam is going to be going through, those organs at risk should be contoured if they have DVH goals or organ at risk goals with mean dose. And then any max dose goals, organs that have max dose goals, if they're within 2 centimeters of the target, they should be contoured as well. So here's some examples. C-spine treatment, you can see the submandibular glands, the oral cavity, the mucosa. These are all included because they have mean dose goals. In addition, the spinal cord is included as a max dose goal, and it's right next to the target volume. Here we have a T-spine treatment. We have the lungs, we have the esophagus, we have a nerve root. I believe the stomach is contoured as well. I don't have that turned on, but the stomach is contoured as well as the heart. So, we're looking at all of these things here. Lastly, we have L-spine with the kidneys immediately next door. The physician drew the kidney cortex in addition to the kidney body. We have the duodenum, small bowel. So everything kind of in the vicinity here has been contoured for the purpose of assessing dose to the patient's organs at risk. Here's an example from my clinic that needed to be corrected before the patient was treated. Patient was receiving SBRT to T12 and L1 with gross disease extending beyond the body. So you can see the PTV kind of extends outside of the body of the vertebral body. The nerve roots were contoured on the involved and uninvolved side. So you can see these green contours here correspond to nerve roots that were contoured and were intended to be spared as part of treatment. However, the T11 nerve root on the involved side, which is located right here, right where the crosshairs are inside of this GTV, was missed. The physician kind of got up there, but then forgot to finish the contours. The dose constraint for this region, this nerve root, was 30 gray, but the physician treated the GTV here up to 44 gray. And so this nerve root was greatly exceeded in the first version of the plan. This was discovered by a physicist. The physician drew a new root here, and then the plan was re-optimized to protect that nerve root. All right, poll question 3. Which organs at risk should be contoured for SBRT of the spine? Start my handy dandy timer, and here we go.
Okay, so there's a question from the audience. So both Astro 2023 and GEPUG 2022 guidelines for spine SBRT strongly recommend 6 degrees of freedom patient repositioning. Is it safe to do without it? because they have a halcyon in their center, and that halcyon couch does not offer 6 degree of freedom.
That's a great question. Oof. If you chose to do spine SBRT without a 6 degree of freedom couch, you would really need a plan for what to do if you could not align the spinal column accurately. That could look like repositioning the patient over and over until things look pretty much perfect. Or that could look like just using a larger margin around the spinal cord in order to increase the sparing and increase like the margin for safety. It's something you'd really want to think hard about. That the 6 degree of freedom couch kind of solves all your problems for you in terms of just making sure that the spinal cord and the spinal column are exactly aligned every single day. If you can't do that, you definitely have to have some sort of safety precaution, whether that's a strategy for repositioning the patient, some sort of on-table device for performing pitch and roll, or a larger margin to protect the spinal column. Okay, the correct answer here is for all organs contoured for stereotactic radiosurgery, like the optic nerves and cochlea. These are the only organs at risk that are going to be outside of the treatment field for spine SBRT. Pretty much everything else in the body is potentially in field because spines stretch the entire length of the body. So,
Justin, I see a lot of answers to be one. So could you maybe quickly go over why one is not a correct answer?
Yeah, so let me look here, make sure I phrased, yeah, so it's because spine SBRT is an SBRT technique and you have, rapid dose fall off. You can sort of ignore organs at risk with max dose constraints that are really far from the target, but really anything within 2 centimeters of the target that has a max dose constraint should be contoured for evaluation as part of spine SBRT planning. So yeah, it's anything within 2 centimeters of the max dose constraint, it's good to have. Anything that's a parallel organ with mean dose and DVH constraints is good. The spine and the cauda equina are always contoured for these cases. It's just brain stuff. Since the spinal cord doesn't stretch into the brain, you don't need brain organs at risk. So for spine SBRT, it's typical to use 2 to 4 VMAT arcs. Typically we have high dose per fraction, and because of the complexity of the geometry of these cases, we have a higher need for modulation. So larger number of arcs is generally beneficial. And we generally employ full arcs because the tumor is in a central location, and so we can get good clearance and more entrance directions. If you're doing IMRT, using 9 or more arcs is a good idea, again, just to have more modulation and to spread out the surface dose as well. If you have a large patient, you're treating in the thorax, abdomen, pelvis, make sure beams don't enter through regions of the CT where the patient anatomy is outside of the field of view. And if there's missing tissue, or if you're treating through if you have arms or shoulders in the field, it's best to avoid treating through those unless they're really well immobilized. So just consider the arms and shoulders for TNC spine. Here's a couple examples of spine SBRT beam arrangements. On the left, you can see for L spine treatment, we have 3 arcs around the patient, almost full arcs. They just kind of, split at the back a little bit. Here, that patient with their arm down because of the surgery, we chose not to treat through the arm. So we have 3 full arcs going, I should say 3 partial arcs going around the patient, avoiding the arm. Generally speaking, for spine SBRT, you want high dose rates. So if you have FFF modes on your machine, you should use them. High dose per fraction, this decreases the delivery time and makes sure the patient spends less time on the table. A higher energy is preferred for beams entering through the abdomen and pelvis due to the deeper depth. So usually we use 10 FFF for pelvis and abdomen in our clinic, and 6 FFF for other, like the T-spine and the C-spine. Energies greater than 15 MV are discouraged due to the high leakage and neutron dose. Maybe if you have a really large patient, this could be considered, but generally 10 MV is enough, especially in a VMAT context, to spread out the entrance dose, get a reasonable skin dose, and get a good plan. Collimator angles in general for VMAT should be varied to get different MLC directions for modulation, but you can use MLC motion to make sure that at least some of the time the MLCs are perpendicular to the spinal cord, and this allows really precise dose shaping around the cord. So this is a nice thing to do when you're doing SBRT planning. And then lastly, the modulation factor is generally expected to be higher for spine SBRT versus other uses of VMAT. due to high modulation needed to spare the spinal cord and have a conformal plan that wraps around a complex target shape. So in optimization, one of the challenges we have in spine SBRT is that the PTV often overlaps with the spinal cord or the spinal canal or the nerve roots or the cauda equina. And so it should be divided into subvolumes that are optimized differently depending on whether the subvolume overlaps with organs at risk or not. And this is a concept we've seen a lot in different other types of planning. I talked a little bit about it in my lung talk when we talked about the lung targets overlapping with the esophagus and lung targets overlapping with the chest wall. So you'll see another example of that here today. One, I guess, special characteristic of spine SBRT is that the PTV almost always overlaps with the spinal cord or the spinal cord PRV. And that means you're almost always planning in a way where you're trying to carve out certain areas and give them different doses. Your optimization strategy may depend upon whether or not you are optimizing to the spinal cord, that is the true cord within the spinal canal, or the full spinal canal. It's good to, in general, optimize on a PRV of the spinal cord, and that's just going to reduce a dose gradient near that organ at risk, right? We don't want like a high dose gradient immediately next to the spinal cord, because then if the spinal cord moves a little bit, it might move into a high dose region. So we kind of want to protect the spinal cord with a little bit of a bubble, and optimizing to a PRV will help with that. Again, we want to, when you're looking at things in the optimizer, we want to make sure anything within 2 centimeters of the target volume is included in the optimization. And again, we want to be screening for conflicts. If the dosimetrist or the planner doesn't divide the PTV evenly into pieces, you'll have some conflicts that need to be managed, and that can make it more difficult to come up with a good plan. So I wanted to give a good example and then an example that could be improved. This is my good example. We have a target volume that's divided into different pieces. So this light pink, this light red area is the part of the PTV that doesn't overlap with organs at risk. So we have a mucosa plus expansion, spinal cord plus expansion. That is carved out of the PTV. And we have this OTV objective here where we're basically trying to get as much coverage as possible to this pink contour. In addition, the GTV is being boosted, and that's just going to full coverage because there's no organ at risk here to overlap. We have lower dose goals placed on overlap regions. So you can see here we're applying a minimum dose goal of 15 gray to the areas that are at risk of overlapping. And then, of course, we have goals applying to the spinal cord or the mucosa that are trying to manage doses to those regions. And in this case, there's no conflicts in the optimization. Each area is sort of being respected in its own way. We're trying to get as much coverage as possible where we can. We are letting the coverage drop a little bit where we need to. And as a result, we end up with a really nice plan for this case. Here's an example of a conflicting objective. So we have, when the dosimetrist made this case, they subtracted the spinal cord plus a margin from the vertebral body PTV, but they forgot to subtract the nerve root from that contour as well. So you can see there's these little triangle areas here that overlap with the nerve root. The nerve root goal is 27 gray. The vertebral body goal is also 27 gray. So this area is both trying to get above and below 27 gray at the same time. So there's a conflict here. You can see in the optimization here, we're trying to get a minimum dose of 27.6. And then the nerve roots are trying to get a maximum dose of 26 or 27 gray. So we have a conflict. The plan ended up turning out okay, but this is the case where it probably would have been easier to plan if there had not been a conflict. All right, lastly, let's talk about dose distributions. In spine SBRT, we want to use a small dose grid because, again, we have these small, intricate structures. We have high dose gradients, and so we want to model those as accurately as possible. And generally, the recommendation is to use a dose grid of 2 millimeters or less for spine SBRT. The target may be undercovered to meet organ at risk constraints and for the spinal cord and the nerve roots and the cauda equina. So this is a case where almost in every kind of patient, you'll end up seeing undercoverage of the target volume. And really what you're going to be looking for, and we'll look at some examples of this, is did we undercover it by the right amount? Did we do it too much, not enough? And really it's assessing the balance of undercoverage, not necessarily trying to make sure that full coverage was gained. So I did something special here. Generally, the target coverage is going to be yellow. or red. And then green is going to be the organ at risk dose that we're trying to achieve for the spinal cord. And so in these examples here, you can see that we got as much yellow as possible. And then our green kind of goes right up to the PRV and stops there. As you can see that the spinal cord doesn't get any green, any of this 22.5 gray. In this case, 27 gray was the goal to the nerve root. You can see that the nerve root is mostly spared from 27 gray. There's a little bit here, but less than 0.3 of a cc, so we're safe. But this will be a very typical dose distribution for a spine SBRT, where we have the tolerance dose going right up to the PRV and stopping at the PRV, or stopping right at the surface of the spinal cord. Similarly, here we have our tolerance dose, 25.5 to the cauda equina, and it's touching the cauda equina a little bit, but not quite entering it. And then lastly, here you can again see that our green isodose line is hugging the PRV, and then we're getting as much coverage as possible away. And then up on top here, we're peeling back coverage a little bit to protect the mucosa. So 3 good examples of what a dose distribution is going to look like in terms of trying to find the right balance between organ at risk sparing and coverage for the target volume. And then this is showing some typical dose gradients. I have a 1 centimeter ring on around the target volume and the 50% isodose line on. And generally what I'm seeing in most of these is that the 50% isodose line is right around 1 centimeter away. Sometimes it's a little bit further away, sometimes it's a little bit closer. Generally the 18 gray isodose line here, which I think is 60%, is staying within the centimeter. This is an exception here. You can see that we are trying to spare the kidneys quite a bit for this case, and so the dose distribution does stretch a little bit more in the APPA direction, but that was done intentionally to spare the kidneys. And again here, 50% and 60% are mostly inside of that 1 centimeter for most of this case. One final point on spine SBRT. When you're looking at the spinal cord and doing a dosimetric evaluation of whether the spinal cord doses were met, one challenge in SBRT of the spine is that there's a bunch of different terms related to the spinal cord that are used. And if you're not careful, you can accidentally use the wrong kind of objective for the wrong definition of spinal cord. So broadly, there's this concept of a thecal sac, which is the bony limits of the spinal canal. That would be like this white area here on this MRI. The spinal cord in spine SBRT is normally what is referred to as the true cord, which is the anatomical spinal cord, the actual bundle of nerves traveling through the thecal sac. And this is generally defined either using T1 or T2 weighted MRI or a CT myelogram. There's this concept of a partial spinal cord introduced in clinical trials, which is the true cord, but restricted to a certain distance above and below the target volume. You can see here is an example of the true cord going 5 to 6 millimeters above and below the target vertebral body. So this is kind of like a standard part of the cord that you can apply dose metrics to. And finally, the cauda equina. In most spine SBRT, it's defined as the entire spinal canal. So cauda equina equals thecal sac for the purposes of spine SBRT planning. In most clinical trials, I have seen my physicians contour the cauda equina separately, but it gets more and more difficult to do that the lower you get into the pelvis. And so very often this is just drawn as the thecal sac and called the cauda equina. So this can be really confusing. If your physician wants to do spine SBRT, make sure you know what protocol they're using and you know the definitions of the structures within that protocol, because you really want to apply the dose metrics to the right kinds of structures. I made this table of 4 different areas where I got definitions. This is RTOG 0613, Canadian trial for 2 gray fractions, NRG BN 002, which is sort of like a oligometastatic metastasis clinical protocol that includes spine SBRT, but it also includes bone mets elsewhere. It includes all kinds of other mets throughout the body. And then of course the energy protocol spine SBRT document. And broadly, there's 2 patterns I want to point out. One, in all of these, for the most part, the cauda equina is defined as the thecal sac, and when you're applying dose constraints to the cauda equina, you use the structure itself and not a PRV of that. In the case of the spinal cord, pretty much all of them, except NRG BN002, use the true cord as the spinal cord definition. And then when you're doing two fractions, There's a PRV of 2 millimeters. You apply your dose constraints to the PRV. When you're doing 1, 3, 5 fractions, you apply it directly to the true chord. But it kind of shows like what variety is out there in terms of how the chord is defined and how different dose objectives are applied. And so the takeaway, I think, is just be really, really aware of what your clinic is doing and be very, very intentional in making sure it's done correctly. All right, let's do poll question number 4. Which of the following is a good practice for selecting optimization objectives in spine SBRT?
So Dustin, so a couple of questions from the audience. So what is the normalization applied in spine SBRT?
Prescription normalization?
Yeah.
Good question. So, you can't achieve very often V100 equals 95%, right? Because you're almost always going to undercover to protect the spinal cord. That means that often your dosimetrist will be setting coverage to something like 92% or 88%. So the normalization is kind of less rigorous in spine SBRT. And very often you're looking more at like, where are the isodose lines going relative to the target volume. So away from organs at risk, you want the isodose lines to be conformal to the target volume. Oh, there goes my 1-minute timer. Maybe I'll go back a couple slides just to demonstrate. You want your, when evaluating things, you want your prescription isodose line to be following the target volume, both at your high dose and low dose levels, and then peeling away to protect organs at risk. And, if the plan is doing this well, then the coverage that you ultimately get is sort of probably the best case coverage you can get. But yeah, I think between 85 and 95% is typical.
And how about like a 4D CT? So do you do 4D CT for spine locations?
We used to, especially when we were first kind of starting it, to make sure that there wasn't any clinically relevant motion, because the anatomy around the spinal cord doesn't move a lot with respiratory motion. And so, the spinal column generally isn't moving, and neither are the organs at risk that you might want to spare. And so we stopped doing 4D CT for those cases. What about you, Minsun? Are you doing 4D CT for spine SBRT?
No, we don't think that breathing is actually important in the spine location, so we don't do 4D CT either.
Yeah. It's a good question. It's something we wondered ourselves when we first started, and we ultimately investigated it and decided not to do.
Yeah. And we don't do any diaphragm control device or anything like that either.
Okay. So the correct answer was number 1. The target volume should be cleanly divided into regions that do and do not overlap with OARs like the spinal cord. So again, that's really important. That means like every little voxel has its own goal, its own objective, and this is the strategy that will reduce the likelihood of having conflicts in the optimization. All right, let's jump into our last topic, which is sarcomas of the extremity. Again, here's a list of references that I used for compiling this talk. There's a really nice clinical practice guideline. Not every Astro guideline has a lot of stuff on like simulations and planning, but this one does. And so I like this guideline in particular for sarcoma. And then of course we have a clinical trial here, which kind of set a lot of the practices that are used in sarcoma planning into place and that are still followed to this day, including things like generating a skin strip for sparing, the contralateral side of a limb. Let's jump right in. So what are some relevant things in patient assessment in the treatment of sarcoma? Broadly speaking, in sarcoma, either you're going to be treating preoperatively or postoperatively, and that's going to influence things a little bit. One, if you're treating postoperatively, you're going to have a scar, and in some cases, there could be some fear of tumor seeding along the scar, and so that might increase the likelihood that you're going to be treating with bolus to try to cover this previously treated region. That's relatively uncommon, but it does happen. In addition, the use of preoperative versus postoperative can influence the target volume. So whether or not you have a boost volume, what the dose of that boost volume is. So paying attention to that will help you understand some of the physician's decision making. In general, it's good to screen for implanted hardware. Patients who have sarcoma may also have implanted metal rods in their body or something like that. Occasionally, bolus is needed for these cases. For soft tissue sarcomas that are superficial, you may want to treat all the way to the skin. This is relatively uncommon. In routine use of bolus is not recommended to help protect the skin if it isn't involved. But if it is involved, you will need to use bolus to ensure full coverage. So it's good to establish that early on and make sure that the right practices are being followed. Let's talk about patient setup. So for spine SBRT, we're talking specifically today about, not spine SBRT, sorry, sarcomas of the extremities. And sarcomas of the extremities are, arms and legs. And so we're going to be talking for the first time in this course really about how do we position arms and legs. And because arms and legs are very mobile and there's many ways they can bend and rotate, it's important to have a custom mold to ensure that the posture and position of the extremity is reproducible on a day-to-day basis. Any mobile non-target anatomy like the contralateral arm, contralateral leg, the head should be positioned away from the target to make it easier to block that anatomy from entrance beams. And of course, pay attention to patient orientation. Feet first setups are very common for legs. This gives better clearance for the machine, allows lower parts of the extremities to be treated on a linear accelerator. And so it's very important to pay attention to which setup was used. In my clinic, sometimes we have a head first and a feet first scan. So it's important to make sure that the correct scan was selected for planning as well. I'm going to show a bunch of different setups because every sarcoma is different, and so every setup needs to be a little different. Here we have a feet first prone setup for sarcoma of the left thigh. You can see this is prone position. The patient's leg is in a deep mold. There's a sheet on top of it, so you can't really see the details of the mold, but we also have the skin marked here to show where we're going to be treating. We have a straightening line, which is very useful when you're positioning patients. So in addition to the 3-point setup, a straightening mark is really helpful. Actually, there's a pair of straightening marks here for this particular setup. This patient is being treated to their left thigh, and their scrotum and some of their skin folds are being taped up and to the right so that they're not in the treatment field and they're a little bit further away from the target volume. So this is a nice practice if you're treating the upper thigh to protect the scrotum and the genitals in general. Here we have a feet first supine setup for a soft tissue sarcoma of the right lower leg. You can see that the leg is kind of already a little bit swollen here. This mold is deep. There's good fixation at the ankle here and at the bottom of the foot, as well as up at the knee, but the physician actually left the kind of mid-calf a little bit more open in order to accommodate some swelling. I actually went back and looked at some of the setup images for this patient, and it swelled more than I thought it would during the course of treatment. So we don't see this practice very often, but for whatever reason, the physician anticipated swelling and had kind of a plan to make sure that the leg would continue to fit in the mold even after the swelling began. And that strategy really was do a good job with the ankle, do a good job with the knee, and the leg will fall somewhere in between. And this strategy was kind of, it worked really well. I'll also note that this contralateral leg is a little bit lower. We like to do this to give our partial arcs a little bit more room to cross to the contralateral side and not go through the opposite leg. Here we have a synovial sarcoma of the left knee. And the right leg here is frog-legged away from the target volume. So this is a nice practice if you're treating close to the knee. You can kind of pull the opposite leg away. Here we have a feet first supine setup for a sarcoma of the right lower leg. And again, the left leg is placed a little bit lower than the right to allow the partial arc to kind of cross to the opposite side a little bit more. The mold is built up around the foot to aid reproducible setup of the ankle joint down here. Really important to get the ankle joint well if you're treating in the lower limb. Here are a couple examples of arm sarcoma setups. Here we have a head first supine setup for a sarcoma of the left arm and shoulder. So we're treating kind of up in the shoulder here. The arm is slightly akimbo. We have the arm being supported by the mold. And we have this is actually a custom headrest that was molded to fit the space around the patient's elbow and left side to try to make the spacing between the arm a little bit more reproducible. So we have some molding around the shoulder, around the arm, and then in between as well. Here we have a spindle cell carcinoma of the left forearm. It's very obvious. You can see it right here protruding from the arm. And we have a custom body mold and a hand mold are used to position the arm and the wrist. So we have basically a mold for the arm itself, and then this custom hand immobilization to get the fingers and the thumb and the wrist in the right orientation. And lastly, we have a head first supine setup for a sclerosing fibroepithelial carcinoma of the right humerus. You can see that we wired the surgical scar. This is a post-surgical treatment. This mold isn't as deep and conformal as I would like. I'd like to see it a little bit more built up here in the armpit. And it's pretty deep and nice here in the forearm, but it's not very deep here in the upper arm. It's hard to see because I've blocked the patient's face, but the patient's head is turned away from their treatment arm too. So we've tried to put some space between the head and the treatment location. All right, Zoom poll number 5. Which of the following is not a good practice in patient positioning for extremity sarcomas? I'll start my 1-minute timer. Minsun, do we have any questions?
Well, I think people are still discussing SBRT spine.
Oh, okay. It's a good topic.
So do you know if we can re-irradiate spine with SBRT? Have you ever seen re-irradiation of the same spine?
Yes. In fact, the Astro clinical protocol discusses this quite a bit. I think I had a table in this talk where I discussed it, and then I decided to take it out, which is what always happens, right? You make a slide, you take it out, and then you get a question about it. This is a great question. The Astro clinical protocol, I should call it it's a clinical practice guideline. The Astro clinical practice guideline discusses this in quite a bit of detail and actually has a table of, this is the dose the patient got previously. This is the recommended dose per fraction for the reirradiation case. And it goes through a bunch of different scenarios, from conventional radiotherapy to palliative radiotherapy. But yeah, spine SBRT is sometimes used in a reirradiation setting. And really what it comes down to is selecting the right prescription dose and the right dose limit to the spinal cord. And it can be done, it just has to be done, safely. And so that Astro guideline is a really nice resource. So the correct answer here is feet first setups should be avoided. This is not a good practice. Feet first setups are essential to treating the lower leg as part of a sarcoma practice. So there you go.
Just a quick question about the extremities. So,
Yes.
Dustin, how important is it to avoid a contralateral, leg?
So there's kind of two aspects to this question, right? One is like how harmful is radiation to the contralateral leg? And how much would the contralateral leg affect the dose distribution to the primary target? The former is, the first question is, having beams pass through the contralateral leg is probably okay. There aren't organs at risk. There are major organs at risk in, say, the muscle of the leg or the bone of the leg that are going to get a significant dose when beams are passing through it as part of treating the other leg. Our main concern with not treating through the leg is it can be difficult to reposition the leg. And so that position might vary day to day. And as a result, if you're planning, hey, this target volume is 3 centimeters deep, and this is how much radiation I need to give to go to 3 centimeters and give the dose I want. If one day the leg is in the way, now all of a sudden that target is going to be 10 or 15 centimeters deep because the leg is going to be attenuating a lot of the beam. And so avoiding the leg is really more about making the plan more robust and avoiding unintentionally attenuating the beam with the opposite leg. So there are cases where you might pack like the legs really close together and treat through both. But whenever possible, we generally try to put the leg farther away from the target and avoid it entirely. All right, it's a great question. Let's discuss registrations. One challenge with sarcomas in general is that they're part of the soft tissue and they're surrounded by soft tissue. And soft tissue is often deformable. And as a result, getting an accurate registration over a large volume can be difficult because the tissue can be deformed. So let's have a look at that here. Here we have a sarcoma of the upper forearm. I'm just going to start a little back and forth so you can kind of compare and contrast the CT and the MRI. The interval between MRI and CT is about 2 weeks. And after a fusion to bony anatomy, there is definitely some deformation of the soft tissue. I think this is a little bit of tumor progression. I think the tumor has actually gotten a little bit bigger, but there's also a little bit of deformation because of the squishiness of the arm and the muscle and the tumor itself being a little bit compliant. This is, I think, a more extreme case. This is a sarcoma of the upper arm. This is the patient with the arm that was placed down and at their side. At the MRI, the arm was placed tight to the side of the patient, but of course at CT, we placed it akimbo to give ourselves a little bit more space and to reduce the amount of skin-to-skin contact that can cause a skin reaction. So this fusion was a little bit more difficult because the relationship between the shoulder and the arm changes as the arm rotates away from the body. In general, the fusion of the primary tumor here right in the middle is pretty good, and then the accuracy of the fusion gets a little bit worse as you go up and down. When you have a case like this, it's good to communicate to the physician the uncertainties of the registration, and particularly where, kind of saying like, hey, I focus most right here near the primary disease, and then the accuracy is going to be less and less good the further away you get from that. So be mindful of that when you're contouring. The physician can generally incorporate that information into their contouring practice and make the contouring as accurate as possible. This, on the other hand, is a best case scenario. So this is a sarcoma of the left leg, and the MRI was acquired one day after CT simulation using a mold created at simulation the previous day. And you can see here that the leg posture is pretty much the same. The shape and size of the tumor is very, very similar. And so this is a case where we were able to get a really, really nice fusion because we did our MRI in the Truman position. This isn't always possible, but if you can arrange it in your clinic, it can be really, really beneficial to the fusion process. All right, let's talk about contouring. Of course, when we're treating in extremities, most of us have, 2 arms and 2 legs. And so laterality is really important, and establishing the correct laterality of the tumor is very important. So, always check to make sure we're treating the right arm. Generally, the sarcoma, if it's pre-surgery, we can see it, and that helps us confirm things. But if we have a post-surgical case, we'll want to pay attention to the laterality, the location of the scar, things like that. It's important to note that in sarcoma, expansions of the GTV to the CTV are not uniform. Because of the way the disease spreads, the disease tends to spread along planes within muscles, and the planes tend to run longitudinally up and down the extremity. And so, the GTV to CTV margins generally are longer in the longitudinal direction of the bone, and then radially around the bone, the expansion is a little smaller. Often a PTV margin of 5 millimeters is typical, but you also see optimization target volumes that are generated to exclude air, skin, maybe even some normal tissues inside of the arm or the leg. Treatment of extremity sarcomas involve organs at risk that are uncommon in other types of planning, such as joints, bones, subvolumes of or strips of skin that might be especially spared to reduce side effects of the treatment. And so you'll want to pay attention to what the physician has asked for. There might be some things in there that you don't normally see. Lastly, this is a relatively small thing, but when treating extremities, sometimes when you have your CT scan, if you're treating like the lower legs, you don't have any part of like the body, and what you end up having is like 2 legs floating in the CT scan. And if you use auto contouring to make the external, it might fail to pick up one or the other leg. And so make sure that your auto contouring for the external picks up all parts of the body that are inside of the image set that you're evaluating. This is from the Astro Clinical Practice Guideline, and you can see here that there's different methods for creating CTVs from GTVs, depending on whether you're pre-op, post-op. When you're post-op, you might have a boost, so there's different definitions for the CTV1 and CTV2 with different expansions. But in general, you can see that, radially, we're doing 1.5 centimeters, and longitudinally, it's more like 3 or 4 centimeters. So fairly large CTV expansions, and these CTV expansions are non-uniform and go in different directions depending on the direction of the muscle fibers. Here are some examples of some contours and some targets. So we have a sarcoma of the left leg. We have a CTV expanded 4 centimeters in the longitudinal direction and 2 centimeters radially. You can see that the CTV does not cross into bone, into the joint. And so generally the CTV is allowed to stop at any sort of natural anatomical boundary. So in one case, we have it stopping at the skin. On the other side, we have it stopping on the bone, but elsewhere it is a 2 centimeter expansion. We also have a strip of skin here. It's very common to choose a strip of skin that's like 3 or 4 centimeters wide and as long as the target volume, and to spare that during radiotherapy planning. The purpose of this is to prevent something called compartment syndrome, in which if you circumferentially irradiate a part of a limb, that prevents the lymphatic system from draining that limb, and you end up with collecting of lymphatic fluid below the area you've treated, and that can be really painful. It can lead to infection. It's generally permanent if it happens, and so it's a really, really bad side effect. And sparing a strip of skin helps prevent compartment syndrome. Here's another example. Ooh, I forgot to change the description on top, but you can see here we have this is the the sarcoma in the forearm. We have the wrist bone, so we have the ulna, the radius. The wrist is a little bit out of the picture here, but it's kind of a little bit higher up. Again, we have a 4 centimeter expansion longitudinally. Our radial expansion is 2 centimeters, although the physician actually did dial it back a little bit to help preserve this skin strip here. So near the skin strip, we have less expansion. Kind of goes to like the middle of the forearm bones rather than a full 2 centimeters. So sometimes these target volumes are modified to help balance the various goals of treatment. All right, let's talk about planning. Conventional radiotherapy is most common for extremity sarcomas. There are some clinical trials out there that are using SBRT, but the standard of care is conventional radiotherapy. Beams and arcs should generally be selected to avoid entering and exiting, if feasible, contralateral anatomy. I think avoiding entrance is most important because that prevents, this issue of unintentional attenuation by contralateral anatomy. But certainly if you're treating near the head, you should avoid exiting into the head as well. Partial arcs are a great strategy to avoid mobile anatomy like the head and contralateral arm or leg. This is also good for clearance. Very often the table is placed very laterally when you're treating an extremity, and so using partial arcs helps avoid collisions between the gantry and the table. Finally, typically sarcomas are planned with 6 MV because these are shallow targets, and 6 MV is generally appropriate when you're treating a target that is shallow in the body. Here's 2 examples of beam arrangements for sarcoma cases, both of which are using partial arcs and avoiding some contralateral anatomy. So you can see here we're avoiding the contralateral foot on one side and the head on the other side. Just a quick note about bolus. Everything that you learned about everything that you learned about bolus and applying bolus and VMAT for breast planning will also apply to extremity sarcoma. The only caveat here is that use of bolus in extremity sarcoma is pretty rare. It's pretty rare for skin involvement in sarcoma, at least in my clinic. I think I looked at maybe 15 different extremity sarcoma cases when preparing for this talk. I didn't see a single one with bolus. I just wanted to note that if you do have a case where you do need to use bolus because of skin involvement, the VMAT flash techniques discussed in the breast radiotherapy presentation can be applied to this body site as well. All right, let's talk about some optimization strategies. Like spine SBRT, it is often the case in extremity sarcoma that we're going to be deliberately undercovering to protect organs at risk in the extremities. I skipped to the second bullet point. So for extremity sarcomas, the PTV is often close to the surface. So while bolus is not necessary in most cases because the tumor doesn't extend the skin, we will primarily evaluate PTV coverage for the volume that excludes the skin. And we'll also optimize to the PTV minus skin to avoid any unnecessary high beam intensity near the surface of the patient that might cause hot spots and skin toxicities. So that's one thing to keep in mind. Our optimization structures will be peeled away from the skin. We'll also have some objectives related to skin sparing with respect to the skin strip. So the physician will ask the planner to minimize circumferential radiation of the extremity. This might involve defining a subvolume of skin or a strip of skin for extra sparing. And you'll want to make sure that there are objectives that are present that promote this type of skin sparing. Occasionally, we'll be treating in the upper thigh. And when that happens, the reproductive anatomy, genitalia, ovaries, things like that can be near the treatment field. And so you want to make sure when evaluating what structures are being included in the planning process Anytime you're treating sort of near the interface with the rest of the body, brachial plexus for near the shoulder, the genitals and pelvic organs near the thigh, make sure those organs at risk are being included. Here's where I was talking about things before. So the PTV for extremity sarcomas often overlap with the skin and bone, and these are organs that are going to be spared, and so there might be conflicts, and you might need to undercover the target volume in order to achieve some of these goals. Lastly, we often try to have uniform dose fall off in all types of radiotherapy planning, but you will more likely see non-uniform dose fall off in sarcoma because of the desire to protect this strip of skin. So very often you'll have more dose fall off lateral to the strip and very fast dose fall off toward the strip of skin. Let's look at a couple examples here. Again, it's really important in cases like this to cleanly divide the PTV into pieces. So we have a PTV that's divided into a skin component, the bulk, and then the overlap regions. This pink area here is the PTV and the skin. This yellow area here is the area that doesn't overlap with the skin and is generally going to get full dose. And this purple area here is the part that overlaps with the knee. And then down here, you can see the skin strip. So you can see we have different PTV goals for different parts of the PTV, all respecting the fact that we're trying to achieve different things in these different parts. And of course, the knee and skin strip are optimized as well. So this is a good example of, again, dividing the PTV into clean parts and optimizing each part separately. This is a more complex example. So we have, again, this OTV, which is the bulk. We have this, what's called SOTV1U, which is a convention we use in my clinic, but it's basically the part that overlaps with the target volume. So this is our overlap region. And then lastly, we have this area here, which is the PTV outside of the overlapping with skin. One thing you'll note is that we also have the wrist at the bottom of the target volume here. And we use the overlap region here to protect the ulna and the radius, but we actually just excluded the wrist entirely from the PTV because the physician really wanted to preserve function of the wrist. And so we have this high dose full coverage region. And it basically just stops at the wrist, and we aren't going to try to cover it there. So we're trying to get full coverage here of the bulk. We are trying to maintain a really tight dose distribution, getting almost exactly 50 gray, no hot spots within the overlap region, and then we're deliberately undercovering near the wrist. So you can see we kind of have max dose goals here, trying to keep the max dose right around 50 gray for the bones. And then for the wrist, we are much more aggressive. We're trying to get a mean dose of less than 19 gray. And so deliberately excluding the wrist from the PTV is going to help us achieve this low dose to the wrist. So again, these goals are all consistent with the physician's desire regarding what organs at risk should get certain doses and protecting the wrist in particular. Like spine SBRT, target coverage might be reduced to meet organ at risk constraints when you're treating sarcoma. One tricky thing is that often a physician will tell you that they don't want the 20 gray isodose line to circumferentially cover the skin. So they'll say in every single slice, I want at least some of the skin to get less than 20 gray. And actually, you can't really make a DVH objective that does this. So you have to actually look at every individual slice and make sure that the isodose lines are breaking apart at 20 gray around some part of the skin. All right, so just a couple examples of sarcoma dose distributions before we finish up here. So we have this left forearm case, and you can see that the PTV is undercovered superficially to spare uninvolved skin. This is one of the things the physician wanted to do. You can see here we have a skin minus CTV, and that's this area kind of, outside of the PTV here. There is part of the CTV that does go to the skin, but not all of it. And so the physician wanted to preserve a lot of this pink area. We discussed previously the wrist. The wrist is being really aggressively spared. And then on the radius and ulna, the arm bones are really, we're just trying to keep hot spots out of those regions. And you can see they're a little bit colder than the rest of the PTV. This has kind of got some 105% in here. There's no 105% in the radius and ulna. This is a case where the physician had a goal for the uninvolved skin, and it wasn't possible to meet that goal. So the physician worked with the dosimetrist to balance PTV coverage and skin dose. You can see that the PTV coverage was decreased quite a bit superficially here. And really the goal of that was to try to maximize as much skin coverage or skin sparing as possible. And sometimes in these sarcoma cases, you do push up against organs at risk and target coverage being in direct conflict, and you have to work closely with your physician to make sure that the plan that they want is being executed as accurately as possible. This case is a bit more favorable. The PTV was deliberately undercovered to protect the knee, but other than that, all of the priority 1 constraints were met for the femur, the knee, the skin strip, the bones of the lower leg. And so this is a more clean-cut case where you can see that we got really good coverage everywhere, except right at the knee, we're pulling away from the knee, but that was consistent with the physician's intent to meet this mean dose less than 15 gray constraint. All right, last poll question. You are reviewing an extremity sarcoma plan. Which of the following is a plan quality issue? And Minsun, this is my last slide, so feel free to send any questions my way.
Yeah, just a quick question. So what MR sequence is used for sarcoma?
There's generally, it's like a typical T1 and T2 pair. Occasionally there'll be a T1 with contrast, although, oh shoot, I'm thinking of the spine SBRT again. I don't remember, or rather I remember, but I don't remember all the details. So I'll write that question down and get back to you on that. Minsun, do you know off the top of your head?
No, I mean, it looks like the one that you showed was a T2 weighted.
Yeah, that was a T2 image set.
Yeah.
But I typically get like 2 or 3 different MRIs to fuse. I want to make sure I provide the right answer. So we'll circle back on that one. Okay, the correct answer
chose 4.
Yeah, 4 is correct. Plan quality issue. The plan treats through the contralateral leg to improve the dose gradient in the AP direction. Generally, as we discussed a little earlier, you want to avoid, sorry, I got a little frog in my throat. You want to avoid the contralateral anatomy. This just helps prevent the dosimetric uncertainty associated with attenuation through the contralateral limb.